Hello and welcome to Ticme, time-critical medical education. My name's Dr. Nick Taylor and I'm an emergency physician at the Canberra Hospital. Today we're going to talk about the basics of ventilation. The goals of today's tutorial are to understand the basic principles of ventilation, to understand the basic ventilator modes, to set up a ventilator for basic ventilation indications, and to be able to identify key end-tidal CO2 waveforms. So what about a case scenario? A 45-year-old man arrives in severe acute pulmonary edema. You decide that he needs intubation and, using your newfound rapid sequence induction and intubation skills, you safely put in the endotracheal tube. But what now? How are you going to set up his ventilation? Let's find out. First, some very basic respiratory physiology. How about starting off in your minds trying to define ventilation and oxygenation? A lot of people put these together, but in reality they're quite separate concepts. How did you go? Ventilation is best thought of as a macro kind of concept. It's literally that air goes in and out and the chest goes up and down. Oxygenation is, however, a far more complex micro kind of concept, and it's influenced by multiple other factors. If you think about a person spontaneously breathing room air, if they were to suddenly breathe twice as fast, their ventilation would double, but their PO2 would be unlikely to change very much at all. It is useful when we're attempting to understand mechanical ventilation to try and completely separate oxygenation and ventilation as concepts. Now in real life, these two things occur together. However, we're going to keep them separate for the time being. Our bodies have been evolving for millennia, and they've adapted very, very reliable servo control mechanisms over time. So what is the very reliable immediate feedback mechanism that we've developed for ventilation? How does our body control ventilation? The primary servo control is the respiratory centre in our brainstem in the medulla. There are pH-sensitive cells which sense changes in the pH in the CSF through dissolved carbon dioxide. Do you remember your equation? Carbon dioxide plus H2O gives H2CO3, which dissociates into H+, which is an acid, and HCO3- or bicarbonate. The respiratory centre responds to changes in arterial carbon dioxide and adjusts the minute volume accordingly. If the CO2 rises in our bloodstream, we ventilate more. If the CO2 falls, we ventilate less. This is an incredibly sensitive system and responds to minute changes in CO2. One of the times where it becomes less sensitive is in chronic hypercapnia, such as in COPD patients. The cells become indoctrinated to the acidic pH and the high CO2 levels, and so the set point moves and the sensitivity reduces. So what is the backup plan? That's right, it's a hypoxic respiratory drive. Central chemoreceptors, such as those in the carotid body, sense our PO2 when it's less than about 50. It usually makes up about 10% of our day-to-day respiratory drive, and you can see that it's not going to be the thing that makes you breathe from minute to minute. Remember, that in patients with chronic CO2 retention, a large proportion of their respiratory drive may be related to this hypoxic respiratory drive. Thus, suddenly increasing a patient's PO2 by putting on high flow oxygen can take away this respiratory drive by increasing the PO2. Next question we have to ask ourselves is, how do we measure ventilation? It's quite simple, really. We use the minute volume. Do you remember what the minute volume equation is? It's not too difficult. It's the volume that we breathe in a minute. So it's the tidal volume times the respiratory rate. So what is the relationship between carbon dioxide and minute ventilation? Yes, it's easy. Carbon dioxide is proportional to the minute volume. Thus, when we're ventilating a patient, we have to become the patient's medulla. And we use the end tidal CO2 number to guide the patient's ventilation adequacy. Remember that the end tidal carbon dioxide will differ from the arterial carbon dioxide. It's usually lower by about 5 to 10 centimeters of water, but it varies substantially with different ventilator circuits and different sorts of lung pathology. And this is because of non-ventilated dead space. So how do you adjust minute volume? Well, it's really easy. All ventilators, even the most basic, such as handbagging a patient, have settings for tidal volume and respiratory rate. The tidal volume used in normal lungs is approximately 10 mL per kilogram. The usual respiratory rate for an adult is 12 to 16. Do you notice that we haven't mentioned oxygen at all in regards to ventilation yet? Oxygenation, as we said, was more complex. It depends on lots of factors, such as the inspired oxygen concentration, the quality and size of surface area available for gas exchange, the amount of perfusion of your lungs in the presence of any shunts, the oxygen carrying capacity of your blood, such as your hemoglobin, and the tissue perfusion at your end organ for oxygen delivery to the tissues. So to decide how much initial oxygen to give our patient when we're ventilating them, we need to use our clinical information such as a history of lung disease or the presence of pneumonia, the SATs that the patient currently has before we intubate them, and even the PO2 if we do a blood gas to guide our initial FiO2. So what's the inevitable third major variable which goes along when we change tidal volume and respiratory rate? That's right, it's pressure. So how does pressure vary with minute volume? Well, it's quite a complex physiological characteristic, pressure, because lung dynamics, particularly compliance and coexisting lung pathology, play a major role in how the lung will respond to a given respiratory rate and tidal volume. For example, a non-compliant lung, which is stiff, will have a higher peak pressure for a given tidal volume. We can measure pressures by measuring the peak inspiratory pressure, or PIP, and the end expiratory pressure, or EEP. If you want to be fancy, you can start measuring things like plateau pressures, which equates to the alveolar pressures. What about PEEP? What is PEEP? PEEP stands for positive end expiratory pressure. All lungs have a low amount of auto-PEEP, which rises in disease states such as asthma. We use PEEP when we're ventilating someone to prevent de-recruitment of alveolar units, so to try and decrease shunt or VQ mismatch. We can use it to increase the functional residual capacity in the lungs. This can be very useful in the obese patient or someone who's been ventilated supine. It also has other physiological effects, such as reducing venous return, or preload, as the mean intrathoracic pressure will rise by increasing PEEP. This can be very helpful in situations such as pulmonary edema. You have to be careful applying PEEP, however, in patients where preload is already compromised, such as a hypovolemic patient. PEEP predominantly helps oxygenation, not ventilation. So, if we're going to set up a ventilator for our newly intubated patient, we have to consider primarily what is our indication for ventilation in the first place. A patient who's been intubated for a non-pulmonary reason should have quite simple ventilation parameters. A patient who's been intubated because of respiratory failure is going to need to have some thought put in before we set up their ventilator. But for a simple ventilated patient, we need to start by dialing up a tidal volume. And we usually start at around 10 mL per kilogram for the tidal volume. Remember, if the patient has ARDS, that's Adult Respiratory Distress Syndrome, you need to use lower tidal volumes. Set a standard respiratory rate of somewhere between 12 and 16 to start with. You can always adjust it. On most ventilators, you need to set a cutoff for the peak inspiratory pressure. Now, hopefully we won't be ventilating our patient to this pressure, but the machine will stop ventilating if it reaches this number. 50 centimeters of water is probably the amount where barotrauma will happen in most adults. I like to set it at 35 to 40, just so I'm aware that pressure's arriving to potentially dangerous levels. We also need to apply some PEEP. In general, most patients can have a PEEP set at 5, but if there is pulmonary edema or pneumonia, aspiration, ARDS, pulmonary contusions, or an obese patient, or even a patient who's struggling with oxygenation, increasing PEEP up to a maximum of around 15 to 20 is a good idea. We then dial up our FiO2. Initially we start at 100% just because of the risk involved in the intubation process, but then we dial it down rapidly depending on our SATs and our blood gas. Here's a picture of a standard Oxylog 3000 ventilator. This is a very common ventilator found in emergency departments across Australia. This ventilator has a dial for tidal volume, a frequency dial, which is respiratory rate, a peak pressure, or Pmax dial. As I said, this is the cutoff pressure, an FiO2 dial, and a PEEP setting. There's also 4 different ventilator modes, and that's what we're going to talk about next. For those of you who are carrying more simple ventilators, it's important to know that these ventilators also have similar characteristics. They have maximum pressure settings, frequency settings, and in this example, a minute volume setting. You can ventilate most patients effectively with a very simple ventilator such as this one. How do you monitor your progress? Remember, if the end-tidal CO2 rises, we have to think like the patient's medulla because we've taken away their ability to respond. So if the end-tidal CO2 rises, we're not ventilating enough. You have to increase the minute volume. And you can do that by increasing the tidal volume, or the respiratory rate, or the peak pressure if we are ventilating on a pressure mode, or we can increase all of them. If the end-tidal CO2 is too low, then we're ventilating too much, and we need to reduce our minute volume. If the oxygen levels or the saturations are low, then increasing the PEEP is the first step. Increasing the FiO2, if this is unsuccessful, is the next step. It's usually better to try and fix problems with oxygenation by recruiting more lung units with more PEEP than it is to just paper over the problem by turning up the FiO2. So, here we are at ventilator modes. In general, the modes are spontaneous or ventilator-driven modes, and then they are either volume cycled or pressure cycled. First cab off the rank is intermittent, or sometimes known as continuous, mandatory ventilation. It's not commonly used in the emergency department because patients in emergency sometimes are waking up, and it's nice to have a ventilator mode which will allow the patient to take spontaneous breaths. Intermittent mandatory ventilation will deliver a set respiratory rate with a set volume and will not allow the patient to take spontaneous breaths. So we need another sort of mode for most patients. This one's called SIMV, or synchronized intermittent mandatory ventilation. This mode creates time windows and allows the patient to breathe within these time windows. Spontaneous breaths are supported by the ventilator, and if the patient doesn't breathe, the ventilator will essentially perform IMV, so it will give a mandatory breath at the set rate. It's the most common mode used for emergency patients because it is entirely safe. It will ventilate them at your set rate, but if the patient wants to breathe, then they are supported by the ventilator to do so. Usually this is a volume cycled mode, in that you set the tidal volume and the ventilator will deliver that volume. What other modes are there? Well, there's PCV, or pressure control ventilation. In this mode, you select the inspiratory pressure and the ventilator will deliver the tidal volume up to that pressure. Now in this situation, the tidal volumes will vary with each breath. In some lungs, and particularly lungs with low compliance and high pressures, such as asthma, having a standardized pressure may deliver a more even ventilation than trying to deliver a standardized volume. The final mode on most transport ventilators is a spontaneous mode. It doesn't have a mandatory backup, so the patient must be breathing and cannot be muscle relaxed. You need to select the PEEP and then the inspiratory pressure support that the ventilator will give the patient with each breath. The combination of CPAP plus the pressure support is the peak inspiratory pressure. It's not commonly used in emergency, as patients are usually not awake and spontaneously breathing. It usually requires a very cooperative patient for this ventilator mode to work well. What about some of the other settings that ventilators have? The IE ratio is the inspiratory time to the expiratory time. In a standard adult, that's usually 1 to 2. But in someone who's got bronchospasm, such as in asthma, the expiratory time needs to be lengthened significantly. Start at 1:3, and you can go out to 1:5 if necessary. The trigger is essentially the flow rate that the patient needs to generate to tell the ventilator that they're breathing. This is usually set at around 3 litres per minute and doesn't usually require any changing. The ramp is a bit more complex and is essentially changing the waveform of the ventilator breath. You can essentially adjust the shape of the inspiratory waveform to change the rate of change of flow. Usually, we ventilate patients with a square waveform, i.e., the rate of change of flow is constant and even for the inspiratory breath. In most circumstances, this is the best mode to ventilate patients. So, back to our case. We had a 45-year-old man. He came in with severe acute pulmonary edema, and we decided that he needed intubation. With our skills, we intubated him, and now we need to set up his ventilator. So, with all ventilators, you just need to start with some basic settings. The process is then to modify as you go so that you can optimize the settings for your patient. So to start with, let's use SIMV. Let's pick a tidal volume of around 600 mils for this 45-year-old man. We need to dial up a respiratory rate, so we'll start with 14 and see how that goes. He's going to be quite sick, particularly with all that pulmonary edema post-intubation, so let's start with an FiO2 of 100 and adjust it down as the SATs allow. PEEP is going to be very important in this patient with pulmonary edema. We're going to use PEEP to decrease preload, to increase the alveolar distension pressure, and to recruit lung units. I'd start with a PEEP of 10 and adjust upwards depending on our saturations. We'd set a Pmax at around 35 to 40, and pressure support is added in if he spontaneously breathes. Start with 15, for example. Remember to frequently monitor, reassess and reprogram your ventilator. We have to become the patient's medulla, and we can't just set and forget. Next, we're going to talk about end-tidal CO2 waveforms. All ventilated patients really should have an end-tidal CO2 waveform. Caloremic color change CO2 devices which attach to an intubated patient are fine for a brief transport scenario where you just need to know that the ETT is in the right place. You do, however, for extended periods of ventilation require capnography. Capnography uses infrared light absorption of exhaled gases to allow a continuous waveform. Remember that it's an indirect measure of the arterial carbon dioxide, and you require it to be calibrated to the alveolar carbon dioxide because of the alveolar to arterial carbon dioxide gradient. And remember we said before, that's essentially because of unventilated dead space. In normal expiration, the end-tidal CO2 reaches and maintains a plateau, which is a horizontal part of the waveform, until inspiration begins. A change in the shape of this graph allows interpretation of the clinical state. This is an often neglected part of ventilating a patient, but it's extremely useful. If the end-tidal CO2 waveform suddenly falls or flattens out, this is usually due to something catastrophic, such as ventilator failure, a loss of supply of power or oxygen to your ventilator, airway loss, such as occlusion or even extubation, a break in the circuit, or even cardiac arrest. Now in cardiac arrest, the end-tidal CO2 waveform falls because blood is no longer being delivered to the lungs. A complete loss of the waveform altogether is usually due to a problem with the monitor itself. Okay, so let's look at the end-tidal CO2 waveform. What we have is essentially a block of expired CO2 with a scale on the left-hand side. Phase 1 of the waveform is anatomical dead space. Phase 2 comprises anatomical and alveolar dead space. And phase 3, when there's a good solid expiration, is the alveolar plateau. The final phase, which occurs at the junction of the plateau with the downslope, is inspiration. That's the orange part of this curve. Okay, so let's look at a few little waveforms. What we have in this one is a series of breaths, and you can see that the amount of end-tidal CO2 in each breath is gradually increasing. Remember, CO2 is inversely proportional to minute volume, so if the CO2 is rising, then the minute volume must be decreasing. So this is hypoventilation. Alright, next, so this is the inverse of the last one we just saw. With each breath, the end tidal CO2 is lowering, which means that we must be getting a higher minute volume, which means this patient is being overventilated. Okay, this tracing shows a single normal breath followed by no EtCO2 waveform. Now, what this could be, if everything's still connected, is apnea, and the patient, if they're spontaneous breathing, that's fine. However, if the patient's using a ventilator, then this should signal something has gone fairly wrong. If the end tidal CO2 monitor has disconnected completely, then you'll lose the waveform altogether. In this situation, there's still a signal going through to the monitor, so the possibilities are the tube could have come out, the tube could be obstructed, or the ventilator could have failed. So be on the lookout for this one. It's kind of important. This is probably one of the most important ones to recognise early. Now, if you compare it to the previous waveforms you've seen, there is no phase 3 or alveolar plateau phase. You can see that this one looks like shark fins, or otherwise known as sometimes alpine breathing, alpine respiration, because they look like mountaintops. So you can see that there's a steep upslope during expiration, and you never reach alveolar plateau. This is because there's trouble with end tidal CO2 exiting the lungs. This is due to bronchospasm or ETT partial obstruction. Sometimes a tracing like this can be the first warning that there's anaphylaxis, for example, to one of your drugs. Very important to learn to recognise these steep upsloping tracings. What about this one? What we've got in the second breath is a nice square waveform plateaued breath, usually consistent with a ventilator breath. Either side of that, there's sort of smaller, shorter, less deep breaths. Any idea what this is? Yep, so this is a breathing patient who's got SIMV ventilation and they're breathing spontaneously, and there's a ventilated breath as well. What about the next one? We have two breaths. One of the breaths during expiration has a drop down in the end tidal CO2. How do you think this could happen? That's right, yep. So if the patient takes a breath during the ventilated breath, they will try and inspire while the ventilator is trying to breathe out. That will cause a drop in the CO2 leaving the tube and being picked up by the monitor. So this is one of the first signs that your muscle relaxant is wearing off. So instead of taking full breaths, the patient will be attempting to breathe not in sync with the ventilator. And this, if you are paralysing a patient, this is a good sign on end tidal CO2 that it's time for more paralysis. What about this one? So if you have a look at this tracing, we never actually got a square waveform. There's never been any great height to the end tidal CO2 waveform, never any great shape. So this is what you sometimes see in an esophageal intubation. So there is some retained CO2 sometimes in the esophagus, and the trap is you sometimes get a couple of little weak CO2 traces that makes you think that you're in, but rapidly falls away. So this is esophageal intubation. This is a slightly quirky one. You often see this one, and especially in hyperdynamic patients, and wonder what's going on. This is cardiac oscillations. Remember that when the heart's pumping, there is a change in intrathoracic volume as blood leaves the heart and enters the heart, and that change in volume can cause a change in the CO2 waveform as it changes the volume and pressure inside the chest cavity. So this is benign, this is just cardiac oscillations. They should be in time with the ECG trace. This is another very important waveform to be able to recognise. Now the difference between this waveform and the overventilation waveform is that there is a sudden rapid drop off from a normal looking breath to very small and not very normal end tidal CO2 waveforms. So this sort of picture is what you see in cardiac arrest. And remember that for the CO2 to be breathed out, it also has to be delivered to the lungs to be excreted. So in a setting of a cardiac arrest, when there's no flow to the lungs,
you get a sudden fall away in end-tidal CO2. It's really important to keep monitoring this, because when you get return of spontaneous circulation during your CPR, you often find the end-tidal CO2 tracing will suddenly return. Alright, let's do some questions.
Question 1. What is the primary controller of ventilation? The SATs, the tidal volume, the arterial carbon dioxide, or the arterial oxygen? And the answer is the arterial carbon dioxide. Question 2. What is the difference usually between the end-tidal CO2 and the arterial CO2? Is the end-tidal CO2 more by 5 or 10 than PA CO2? Is the end-tidal CO2 less than the PA CO2? Are they the same? Or is the end-tidal CO2 less than the PA CO2 but varies with dead space? So although answer B is correct, answer D is more correct, that the end-tidal CO2 is less than PA CO2 but varies with dead space. Question 3, PEEP. Does PEEP increase the functional residual capacity, decrease the functional residual capacity, increase venous return, or decrease venous return? Now the available answers are 1 and 3, 1 and 4, 2 and 3, and 2 and 4. Do you remember from the tutorial? PEEP increases functional residual capacity and decreases venous return. So the answer is B. 4. A patient who's 55 is a male and he has pneumonia, is currently being ventilated at 12 times 700 mils, that's the tidal volume times respiratory rate, peak pressures are 20, the PEEP is 9, and the end-tidal CO2 is 55. Now remember, the end-tidal CO2 of 55 is likely to be associated with an arterial CO2 that's at least 65. How do you respond to this? Should you increase the PEEP and the respiratory rate? Should you increase the respiratory rate and the tidal volume? Should you decrease the PEEP? Or should you increase the respiratory rate? Now in a 55-year-old male, 700 ml tidal volume is likely to be about right. So, as you know, with a high CO2, we have to change the minute volume. And if the tidal volume's already okay, then what we need to do is increase the respiratory rate. So the answer is D. Question 5. A young lady who's been involved in a motor vehicle accident is intubated. She's currently on SIMV. She's on 80% oxygen. She's been ventilated with a respiratory rate of 15 with tidal volumes of 500 mils. Her peak pressures are 25 and she's on 5 of PEEP. Someone does a blood gas for you and the PO2 comes back at 64 and the PCO2 is 38. How will you respond to this? Will you increase the FiO2? Do you need to increase the PEEP and the minute volume? Do you need to increase the PEEP only? Or do you need to increase the FiO2 and the minute volume? If we have a look at our numbers, the patient's predominant problem is hypoxia. The arterial CO2 is normal. And if we look at our parameters, we're already on a very high oxygen level at 80%, but our PEEP is only 5. Remember, in trauma, common reasons for hypoxia include pulmonary contusions. Increasing PEEP in this scenario should help out your oxygenation. So the answer is C. Question 6. A 77-year-old lady with an intracranial hemorrhage is being ventilated at 16 times 480 mils, peak pressures of 20 and PEEP is 6. Or on an FiO2 of 0.7, that's 70%. Now the end tidal CO2 is 21 and the PO2 is 256. What would you change here? Would you decrease the PEEP and the FiO2? Would you decrease the respiratory rate and the tidal volume? Would you decrease the FiO2 and the minute volume? Or would you increase the respiratory rate and the tidal volume? Let's have a look. Our end tidal CO2 at 21 is almost certainly going to be associated with a low arterial CO2, although we can correlate this with a blood gas. Just a tip, when you get a blood gas printed out from your machine, make sure you write down what your current end tidal CO2 is on the blood gas. That allows you to calibrate your end tidal CO2 with your arterial CO2. So back to the patient. They have a low carbon dioxide, which means we're ventilating them too much. So we need to reduce the minute volume somehow. Now if we look, she's already been ventilated 16 times a minute at 500 mils. So 500 mils is probably okay, but 16 may be too much. And the PO2 is 256. Now although this isn't dangerous, we can reduce the amount of oxygen we're giving the patient. So in this situation, we need to decrease the minute volume, and you could change the respiratory rate or the tidal volume or both, but I would probably reduce the respiratory rate to start with. And you need to decrease the FiO2. So I would bring the FiO2 down from 0.7, say to 0.5 to start with. Question 7. There's a 45-year-old man, and he was intubated because of benzodiazepine overdose. Because he's waking up, he's breathing spontaneously on CPAP pressure support via your ventilator. The settings are PEEP of 5, pressure support of 15, FiO2 of 0.35. He's breathing at a respiratory rate of 18, and he's breathing tidal volumes of 800 mils. His end tidal CO2 is 22, and his SATs are 99%. What would you do here? Well, let's look at what the problem is. At the moment, his end tidal CO2 is a bit low. If a patient's got normal lungs, then it's likely that they also have a low arterial CO2. So how do we help this man bring his CO2 back up to a more normal level? Well, we can't control his respiratory rate because he's breathing spontaneously, and we haven't set the tidal volume because he's doing that by himself. But we are supporting his tidal volume with pressure support from the ventilator. So in this situation, he needs to have the pressure support decreased, and I'd probably bring it down to 10. In most patients, a PEEP of 5 and pressure support of 10, whilst breathing spontaneously, is sufficient to allow extubation if they're alert and oriented. Final question is a real photo from one of our monitors in the resuscitation bay. The end tidal CO2 waveform is the solid blue waveform at the bottom of screen. What is the problem? If you have a look at the scale, the end tidal CO2 is peaking above 60. Does it look like a nice square waveform? These are the classic steep waveforms or mountains. Do you remember what they were caused from? That's right, it's bronchospasm. So this is a patient who, although the respiratory rate is quite high, has bronchospasm and is hypoventilating because the end tidal CO2 is above 60. Remember that the arterial CO2 is likely to be much higher than this. For a patient with severe asthma, tolerating a high CO2 may be what's required to be able to ventilate them safely. Thank you very much for listening to this tutorial. We'll see you next time on Ticme.